Hi, good evening and welcome to this Trauma Care webinar. My name is Andrew Ormerod and thank you so much indeed for joining us on this Wednesday evening. And so I can already see people in the chat engaging. So please do use the chat and please do tell us what you do for a living, where you are dialing in from tonight, geographically, of course, and also what interests you around pre-hospital emergency airway management. So I can see Alan, good evening, Alan, Kate, Gordon, Jessica, Jan, Dave, Alexander, Daniel, good day. That sounds very Australian. Happy, beautiful evening, all. Paul, happy evening, Paul. Gordon, oh gosh, it's moving too quick now. I can't see it. I can't keep up with that. Right, so for those who have not been with us before, this is a webinar disclaimer that says whatever Dr. Kate talked about or teaches tonight is not a license to do whatever you fancy doing. As long as you stay within your scope of practice and your individual qualification, you won't go too far wrong. So please don't take this learning tonight as a license to practice anything out of your normal scope of practice. And I always say to people, there's a massive webinar disclaimer on the Trauma Care website. Please go and have a look at that. It's pretty much like one of them disclaimers where you scroll to the bottom on your Apple device, then just click accept because you're so excited. So it's very much like that. So webinar rules and facts. Me and Dr. Kate cannot see or hear you. So if you're sat there in your terry toweling dressing gown, or maybe you've decided to sit there perhaps tonight in your boxer shorts, we can't see you, so you don't need to worry. And equally, we can't hear you, so you don't need to scamper around trying to press the mute button. For those members of Trauma Care, you will get a CPD certificate, and that will come automatically to you at around 9 o'clock, 10 o'clock in the morning once the admin team have had their first cup of coffee. For those people who are not members of Trauma Care, I will show you how you can do that easily in a second. And a copy of the recording, again, will also be available tomorrow, as well as also on YouTube for catch-up. There will be some QR code scanning capability tonight, so please do at the end, if you have a QR code scanner or a mobile phone, then you can point it at the screen, scan the QR code and take part interactively. Of course, we always like to see what you're up to tonight on Twitter, so please do share your selfies with us using hashtag TraumaCare2022. This year is just moving so quick, isn't it? I looked at the calendar this morning, it was February. So please do share your Twitter photos with us. Always good to see how relaxed your learning is tonight. So maybe do a selfie. Maybe even, why don't we do a Trauma Care Pets evening? So maybe if you sat there stroking your dog or your cat's on your shoulder or your parrot's on your knee, then maybe take a selfie and share with us on Trauma Care, at Trauma Care UK with hashtag TraumaCare2022. You're probably very much aware by now that we have had to move the conference forward to the end of the month, end of the year, sorry, October. So we've moved from March to October, but it's the same conference program, still amazing ticket prices from only £40. So please, you can scan that QR code, jump over there and grab your ticket. What I will tell you is this 25th anniversary conference is going to be one not to miss. I'm quite privy that I sit on the Trauma Care Council, and it is pretty exciting to hear some of the great things that's going to happen at this year's Trauma Care Conference. And also, of course, we have got an amazing poster competition. So if you're either a nurse or a doctor or a paramedic or anybody, in fact, who's preparing a poster as part of your academic study, then please do get in touch with the Trauma Care team and we can help facilitate the poster competition, and that will be your time to shine. If you are not a member of Trauma Care, then please do consider becoming a member. And again, we've got some amazing proposals coming soon from the Trauma Care Council and the executive team around membership and some great new benefits for students. So please do consider joining us at traumacare.org.uk, where membership comes with lots of tangible benefits, including, of course, your CPD certificates from attending these amazing live events, as well as lots of other great offers like access to the digital journal and some other bits and bats, as you can see on screen. We are always on the lookout for CPD champions here at Trauma Care. So we really would like you to scan that QR code and download the CPD poster. But more importantly, if you're interested in helping support the Trauma Care brand, more importantly, becoming almost either a student affiliate or a member affiliate, then please do let us know. You can either pop it in the chat, just put, yes, please sign me up, and I will get one of the admin team to sign you up to that. But we really need some support in helping share these posters and our great webinars and conference events around the country. So please do pop in your chat. Yes, please sign me up, and one of the admin team will make sure that we contact you in the next week if you're interested in becoming a Trauma Care ambassador and helping us support the Trauma Care brand. that's enough for me chatting away. I'm going to hand you over now to Dr. Kate, who's going to talk all pre-hospital emergency airway management. And I'm pretty excited for this. So Dr. Kate, over to you.
Thank you very much. I'll just sort out my screen sharing. And right, thank you. I can't quite decide if I'm more nervous doing it this way or doing it in a normal auditorium, but hopefully it will all go okay. I'm just going to take my video off if I can, whilst I talk to you. Right, so there we go. So I'm Kate Crewdson. I'm an intensive care consultant at North Bristol NHS Trust. I'm based at Southmead Hospital in Bristol. And I'm very grateful to be invited to speak on this tonight. I'm very excited to have such a wide audience as well. So I just want to give you a little bit of my background first. Just get this. So I trained in anaesthetics originally, had a bit of a stopgap to have my first girl, Ella. Did a bit of HEMS in London. Was very fortunate to do that and had a great time doing that. Moved on through intensive care, so completed all my intensive care training, had another little stopgap and ended up with twins. And then I'm now, as I say, at North Bristol NHS Trust as an intensive care consultant. During the time I was sort of, in the last 5 or so years, I got talked into doing MD with UCL, which was a fantastic thing to do, a reasonable amount of work with quite a lot going on, but a great thing, and that was focusing on advanced airway management in the pre-hospital setting. So hopefully I can give you a little bit of information tonight. So I'm mostly hoping to address some of the key questions today. I may not be able to answer them all in full, but hopefully I can add to some of the existing knowledge base. Specifically, I'm going to look at whether or not there's a role for pre-hospital emergency anesthesia, and within that, how we can actually optimize the process that we go through when delivering this intervention, and then just a little bit around the governance and safety and how we can improve the system from that way. So there's quite a lot that we don't know about pre-hospital emergency anesthesia, but there's some things that we do know with absolute certainty. So we know that poor airway management can have profound detrimental effects on the patient. We also know that airway compromise is a major cause of preventable death in trauma patients. And interestingly, whilst that's reduced with developments in pre-hospital emergency medicine, it's still significant. So it's sort of suggesting that perhaps we're missing something, or something is still not quite hanging together. And there was a recent paper that looked at preventable death in trauma, and it recorded an incidence of airway obstruction as the cause of death in 19% of cases. So, you know, a fifth of patients still have airway obstruction as their cause of death. And in 3/4 of these cases, that was associated with neurological injury. Now, there's other facts that we know as well. So we know that providing definitive airway management is usually a time-critical intervention. We know that physiological derangement is detrimental to survival, particularly in traumatic brain injury. We know that a significant proportion of the patients we attend have partial or complete airway obstruction on scene. We know that provision of the pre-hospital emergency anesthesia is inconsistent throughout many countries, really. And even within the countries itself, I think often is inconsistent. And we also know that if you perform tracheal intubation without the use of drugs, it's universally associated with a poor outcome. So all of this suggests that there is a need for pre-hospital anesthesia. Also, we know from much of the evidence that we see that there is that the availability of effective interventions effectively reduces over time. So as you get your towards definitive care, so where you can have more interventions available, the effectiveness of those interventions reduces. So again, we need to be managing these patients really early on, definitively in their pathway. So all of this is saying to us, I think, that there is a role for pre-hospital emergency anesthesia. And if you look through the data, some of it not so recent, but actually all relevant, there's multiple studies that indicate that a proportion of patients who are in need of emergency airway interventions do not receive appropriate management until they arrive in hospital. There's quite a lot of data that's come out of the US that suggests that 10 to 20% of patients who required urgent airway intervention, who needed to be intubated basically within the first 2 hours of trauma centre arrival, had emergency indications for intubation, such as airway obstruction, severe hypoxia, low GCS, or even cardiac arrest. And these people hadn't had definitive airway management prior to that. In the UK, it's reported that up to 60% of major trauma patients have airway obstruction on scene. Data from TARN, which is a Trauma Audit and Research Network, as I'm sure you all know, suggests that a significant number of patients require intubation within 30 minutes of arriving in the emergency department. And this is one of the quality indicators that they use. And the fact that you're needing to intubate that many patients so early on suggests that there's a real unmet demand and that these patients should have received definitive airway management earlier in their pre-hospital or in their patient pathway. So I think there is a big unmet demand, and I'm going to touch back on this later. But even if we think that there's sort of an unmet demand, then there's also a number of other things that we don't know. So we don't really know which subgroup of trauma patients really benefit from pre-hospital emergency anesthesia. We think we have ideas of the indications, but perhaps don't know all of them. We know that less experienced providers probably don't perform the intubations quite as well, but this is what we'd expect, because if you're a anaesthetist and intubating is your day job, you should be better at it than people who don't do it daily. And we don't really know what factors influence the decision to intubate, and we can't really account for that, and that kind of real feeling that patient needs to go to sleep. So there's loads of stuff that we don't know about it, and I'm going to try and unpick a little bit of it. The trials themselves are really difficult to conduct as well. So it's quite hard to demonstrate a survival benefit in patients who receive pre-hospital emergency anesthesia. And this is probably multifactorial in origin. I think if people need to go to sleep on scene and can't wait until they arrive in hospital, then that indicates that they're sicker and are going to have a higher morbidity and mortality. But this meta-analysis I've highlighted here was produced in 2017, and it's attempted to directly address the question of mortality for pre-hospital and emergency department intubation. And the authors demonstrated a higher mortality rate in patients undergoing pre-hospital intubation, which is pretty common actually. But this is 48% versus 29%. And I think that what this is reflecting is the fact, again, as I say, that if for patients, you tend to put sicker patients to sleep earlier, especially with more capability of the delivery of pre-hospital emergency medicine, then I think you are really coming up against that. And there's lots of confounding factors. If you pick apart all these studies on pre-hospital emergency anesthesia, they use different drugs, different providers. The ISS cutoff is different for the patients. So it's quite hard to compare everything. But if you do subgroup analysis, so as the authors here did, where they adjusted for ISS, GCS, and the level of provider. So those three key things: how sick the patient is, what the GCS was, what level of provider was delivering the intervention, then there was no significant difference in the mortality between pre-hospital intubation and emergency department intubation. And that's pretty telling. So much of the early research came out of the United States, and this is, I would say, arguably when there was an increasing interest in pre-hospital emergency anesthesia, and this is obviously the San Diego Paramedic trial. And the data that they produced didn't support the use of pre-hospital RSI, or as they put it, or pre-hospital emergency anesthesia. And there's a few really interesting things that come out of this paper. So they basically took 209 major trauma patients and they matched them to 3 times the number of controls, so 627. And the criteria for being in the study was GCS 3 to 8 and people who are unable to intubate without the use of drugs. But the drugs that they used were midazolam and suxmetholium, which obviously is a little different from what we're doing now. They found the mortality was much higher in the RSI group, so 33%, compared with the control group, which is 24%, and that was statistically significant. Also, the proportion of patients with the classified as a good outcome, which was quite a bit of a spectrum of what we might refer to as sort of good or moderate outcome from TBI, that was lower in the RSI group compared to the controls. So there really wasn't any benefit being demonstrated here. There was more hypoxia, scene times were longer in the RSI group. Hyperventilation was actually a major problem, and they found that some patients were arriving at hospital with a PaCO2 of 25 millimeters of mercury, so down sort of 3 kilopascals. And this is obviously a problem in the TBI group, and even within that RSI group, that was associated with a higher mortality just within that group, it's not even looking at the controls. The intubation rate was quite high, 16%. They commented in the study that they did it with obviously using manual inline stabilization, that they had cricoid pressure or Selleck's maneuver applied, and all of these things we know make life a bit more tricky. So lots of reasons, I think, why this study was as it was, but lots of stuff come out of that, and lots more research has been done after that. I just wanted to comment a little bit on the traumatic brain injury. There's quite a lot of data that says intubating patients with TBI, as the Davis study, the San Diego Paramedic trial, found, saying that it doesn't work. There's a couple of papers that say it does, and there's basically this meta-analysis which quite nicely sums it up afterwards, which says effectively, if you know how to intubate in the pre-hospital setting, then you can probably do it. You can probably give the patient a chance at better outcomes. So those people who are not so skilled, the patients have an increase in mortality, whereas those people who know who are trained in pre-hospital emergency anesthesia and who are intubating those patients in a controlled fashion may improve the outcome, but not a definite signal, but a suggestion. So I sort of have this theory that we can pick apart this process and we can break it down and come up with a perfect recipe. So we need to intubate the right patient at the right time, using the right person with the right intervention. And so there's loads of stuff that we can influence. So it's kind of the concept of marginal gain, I guess. So we can pick our patients, we can pick our providers, what intervention we're using, whether it's basic or advanced airway techniques, what equipment we're using, what drugs we're using, how we're going to manage failed intubation, etc. So there's loads of stuff that we can do to pick apart here. And I'm going to talk individually about each section. So firstly, looking at when we do it. So do we intubate in the pre-hospital setting? Does it need to be a pre-hospital intervention? So I actually did a study on this as part of my MD using data from the Trauma Audit and Research Network. And the aim of the study was to investigate for UK major trauma patients whether there was an unmet demand for emergency intubation outside hospital. So we also looked at the mortality of patients within this group, and we hypothesized initially that it's likely that the proportion of patients who receive emergency airway management in the emergency department actually represent an unmet demand for airway intervention in the pre-hospital phase of care. So if they're needing it quite quickly after they arrive in hospital, they probably needed it much earlier in their pathway. So we tried to sort of formalize this into a hypothesis and then generate a study. And I'm just going to walk you through a little bit of the data. So in total, this database was quite unwieldy, with 70,550 patients. And boiling that down, I found that just over 11,000 had urgent airway interventions recorded. And urgent airway interventions were defined as airway positioning, insertion of a pharyngeal tube, which was either a nasopharyngeal tube or a Goodell airway, etc. The use for supraglottic device or tracheal intubation. And essentially, I looked at these patients in 3 separate groups. So I looked at the patients who had pre-hospital airway interventions, and I looked at the patients who had emergency department airway interventions. And within that emergency group, separately looked at a group who were intubated in the emergency department, and the group of patients who had non-intubation interventions outside hospital and then subsequently required intubation. So you've got your pre-hospital intubation group, your ED intubation group, and then you've got your group who needed some form of intervention outside hospital that wasn't a tube, who then was subsequently intubated in the emergency department. And so I'm just going to focus in on the group. If you just focus on that group who had tracheal intubation within the emergency department, and we'll pull that apart. And what we found when we did this was that the mortality overall was 27%, but the pre-hospital mortality was much higher. But the ED mortality was 21%. And actually, the group who did really badly, as we'd expect, were the group of patients who needed some kind of intervention outside hospital, but weren't intubated, and then were intubated on arrival in the emergency department. So their mortality was 50%. That's huge. So further picking that apart, I also looked at using the sort of quality indicator of being intubated within 30 minutes of hospital arrival. And even those patients who didn't receive any form of pre-hospital intubation, 75% needed intubating within 30 minutes of hospital arrival. So again, that's really telling you that these patients are poorly and probably potentially should have had something done earlier. Moving to the group who did require or did receive, perhaps more accurately, did receive a non-intubation intervention, over 90% of them needed intubating pretty much on arrival in the hospital. So that's telling you quite a lot about this group who have there is definitely an unmet demand for that patient group. And it makes sense. I think it's what we would glean from all of this. So you have to pick the right patient. You have to think about who you're going to intubate. Sometimes it's really obvious. You get to a scene and you know that the patient that you're dealing with is really unwell and needs to go to sleep. They might be in cardiac arrest, that's obvious, and etc. But then you can often tell. But there are factors that come into play, and I'm sure that people in other countries experience this more than we do in the UK, but distances that you're traveling, etc., must influence all the decision making. But I think crucially, you've got to know when you should do it and when you shouldn't do it. So you need to have clear indications for when you're going to do it. And we know those, don't we? So patients with big traumatic brain injury, they're unconscious or agitated. Often those patients need to go to sleep. The agitated group, I guess, are a bit less black and white, but people who are unconscious with a bad TBI or presumed TBI, they obviously need to go to sleep, and we have to do neuroprotective strategies straight away, because we know that any hypoxia, hypotension, anything like that is detrimental to the outcome for these patients. So we must be really on top of that. Patients with airway compromise or ventilatory failure, we're going to intubate them because we know that those things contribute significantly to pre-hospital mortality. And sometimes a little bit more vague, the anticipated clinical course or humanitarian reasons, really bad injuries or bad burns, you might consider putting them to sleep for humanitarian reasons. And often, if you know that the patient is likely to go straight to theatre once you get in hospital, then that at times can be an indication to go to sleep outside hospital. But there's caveats to those last two. It's really important to know when not to do it. So you need to think carefully about specific patient groups. If you're confident with children, that's great. But I think a number of people doing pre-hospital care don't have huge experience with certainly intubating sick children. And this is a group to be thoughtful about. Hypovolemia, sepsis, really difficult scenes or locations might influence your decision-making. Short transfer times, again, may influence it. But I wanted to focus in on hypovolemia, and this was a study that was aimed at comparing mortality rates for hypovolemic trauma patients who undergo anesthesia outside hospital. So we took a group of patients and we went through the database to identify patients who met certain criteria. So a systolic blood pressure, initial systolic blood pressure. So as soon as you put the blood pressure cuff on scene, systolic blood pressure of less than 90 and a GCS of 13 to 15. And the reason for the high GCS used to select out this patient group was that it demonstrates an absence of major neurological injury. So the hypothesis for the study was that if the hypotension was secondary to hypovolemia, then induction of anesthesia may precipitate cardiovascular collapse. And if this occurs outside hospital following major trauma without access to a full range of resuscitation techniques and surgical intervention, then you're likely to have a higher mortality than if you wait till hospital arrival. And I think to an extent we know this because, if we have a big bleeding aneurysm to put to sleep in theatre, we tend to wait until the surgeon's prepped and ready. So that was a hypothesis that if patients are hypovolemic and they go to sleep outside hospital, that they will have a higher mortality. And in those cases, it may be that the benefit of intubating outside hospital is not outweighed by the risk. And obviously that's what we're looking to analyse. So the results showed that in the cohort of patients who are anaesthetised on scene, the odds of dying were 10 times greater if you had hypovolemia. So if you're putting those patients to sleep outside hospital, you've got a 10 times higher risk of them dying. And that was adjusted for age, the mechanism of injury, the heart rate. And actually the unadjusted odds ratio was 13.12. So in those patients who are not anaesthetised on scene, there was no statistically significant difference in mortality between those patients who had severe hypovolemia. So within each group, so the patients who were intubated on scene, we looked to see whether they were hypovolemic or not. And similarly, for the patients who weren't intubated on scene. And as I say, there was a 10 times higher risk of mortality if hypovolemic patients were intubated outside hospital compared to when they arrived in hospital. So you need to pick your patients, you need to pick the provider. And we know that there's been a few studies that look at this. So we look at physicians versus non-physicians, anaesthetists versus non-anaesthetists. So we know that if you intubate somebody outside hospital, there's a variety of complications, including hypoxia, hypotension, tube misplacement, etc. So there was a couple of meta-analyses which have been done analysing the intubation success rates of physician versus non-physician providers. And the data shows, I guess, what we would think. And again, it goes back to what I said earlier. People, if you have somebody who, it doesn't really matter what the background is, that's irrelevant. If you have somebody who does lots of intubations, if you took anybody and taught them to intubate hundreds of patients, then they're going to be better at it than people who don't get the opportunity to intubate hundreds of patients. So whilst we're sort of using terms physician, non-physician, etc., doesn't really make any odds. It depends purely on training and experience. So how experienced, the more experienced the provider, the more likely you are to have a high intubation success rate. And that's exactly what the study showed. And it basically said that the overall success rate for intubation was around 96%, 96.9%. And that for physicians, it was about 91, for non-physicians, about 91.7, and for physicians, it was 98.8. So this is just showing you, exactly as I said, that people who have more training in intubation are probably going to be better at it. And similarly, the data is the same for anaesthetists and non-anaesthetists. And I think this is highlighting to us how important training is in providing this intervention. You do need to have the right team. And I think this was something that came over particularly, I mean, I guess in every aspect of what we do, but during, particularly during my time with HEMS and even working in trauma teams in the hospital and with the team in intensive care, I think if you work with people who are experienced and motivated and you all believe in the same thing, you're all at the same start point, getting to the same end point, then that's really powerful. You need to recognize everybody's value. There needs to be clear task allocation so that everybody knows what the other person is due to be doing and everybody does their roles properly. There's always an expectation of high performance. I think one of the things that stands out, I've put at the bottom, is mental attitude and preparedness. And I think one of the things that was highlighted is that if you are working in the pre-hospital setting, you anticipate at the start of your shift, you think about the fact that you might end up doing intubation, thoracotomy. You never know quite what's going to be around the corner. Whereas if you're in theatre, anaesthetizing people for bunions and putting LMAs in, then you're not really prepared for it all to go horribly wrong very quickly. So I think it's really important to the mindset of the provider is really important. And I think you have quite a different mindset working in the pre-hospital setting. We need to think about what interventions we're providing. And I mean, I'm going to come on to it, but there's not strong signals from the data, I'll talk about it in a minute, about the correct intervention. And the bottom line, the really key bit for this is that whatever you're doing, do it really well. You can ventilate patients quite well with nasopharyngeals and bag valve masks. So you do need to really be thoughtful about what you're doing and just make sure that you do it to the absolute best of your ability. And I've put in this slide just because I wanted to highlight the fact that nobody's really sure. This is all cardiac arrest data, as you all know, but nobody's really sure exactly what the right thing is. There's no strong signal of one technique being better than another. There was the lead author on the Henry Wang, I know, has stated that he thinks that the LMAs are probably the way forward. And obviously we mostly use LMAs in cardiac arrest, but interestingly, there wasn't a strong suggestion of intubation being that much better than either bag mask ventilation or supraglottic. So it's important to be really thoughtful about this and make sure that whatever intervention you're providing what your team is capable of delivering to the highest standard. So you just need to get it right the first time. So make sure, do all the small stuff that's going to make your intubation attempt successful. And this is not just for the pre-hospital setting, this is for any any time that we're intubating patients or managing airways, make sure you can access the patient. Obviously, when you're outside, make sure it's shaded, make sure during the sunlight, make sure it's lit at night, make sure that you've got all your drugs and kit available. I mean, certainly in the intensive care I work in, we use checklists, we identify everybody's roles before we embark on the procedure. We, again, make sure that we have the drugs and the kit, the airway trolleys checked every day. I think it's really important, particularly in the pre-hospital setting, to think about the position of the patient where possible, have the patient on a trolley at the right height. There's lots of data that shows that if you're trying to intubate patients at the wrong height, that you can't get everything lined up. When you're sort of looking, you've got that line going from your eyes down into the mouth, into the glottis. And if that goes awry, because you've got the patient at the wrong height, you make your intubation harder. I'm really an advocate of thinking about what to do if it goes wrong before it goes wrong. So I think this is, again, a lot of particularly pre-hospital services, but perhaps even in hospital now, so people are verbalizing failed intubation plans, which is really important. And again, when you're working outside hospital, be constantly thoughtful about, where the ambulance is, how you're going to get the patient to the ambulance, how you're going to get off scene, which hospital is your most appropriate to go to. So be really on the ball about that, because you just want to shorten your scene times and just providing the interventions that are completely necessary. Make sure your equipment is standardized, I would say. Keep it simple. I don't think there's a role for lots of fancy airway kit myself. I think if you produce lots of fancy kit, people don't necessarily know what it is or at times what to do with it. So keep it simple so that everybody knows what you're doing. Keep it limited, make sure it's checked. Stuff isn't always as it seems. This label states that it's a ProSeal LMA size 5, but actually it's attached to a speculum. So clearly that's not going to be very beneficial. Similarly with drugs, make sure that they're pre-drawn, because or where possible, I think pre-drawn drugs are very helpful. I know not everybody has access to that. Again, limited choice. I don't think you need, if you look at sort of the picture, you don't need rows and rows of drugs to choose from when you're trying to perform an emergency intubation. The key thing, and something that I am quite focused on, is using, sort of really thinking about your doses. So the standard recipe, I guess, is a 3-2-1, 3 mites per kilo of fentanyl, 2 milligrams per kilogram ketamine, 1 milligram per kilogram of rock. But you may need to modify that. So if you've got somebody who thinks bleeding, but you want to put to sleep, or somebody who's very septic and hypotensive, somebody who's old and frail, you might want to reduce or omit your opioid choice. Ketamine traditionally was felt to increase intracranial pressure, and really everything's moved away from that now. I personally like it as an induction agent in emergency anesthesia, and it's very popular now. I think it's important to think about, it's very important to think about doses, and often I believe that people should verbalize the doses in mics or milligrams and in mils, so how much they're actually going to give from the syringe that's in their hand, because in the heat of the moment it can get a bit confused, especially when you're converting fentanyl at 50 mics per mil and ketamine at 10 milligrams per mil, etc. I think it's important to have that conversation first, very briefly, but necessary. If you think the airway is difficult, I think it's really difficult to predict a difficult airway. So in 50% of cases, the airway is not predicted as being difficult, and it turns out to be difficult. I've put succinylmethanium there. I don't really use it. I'm not sure that many people do now, but it's obviously the traditional agent if you think an airway is difficult. You can increase the dose of rocuronium if you don't have a bailout option, which arguably, if you're anesthetizing a patient outside hospital, you should be fairly confident that you don't have a bailout option. If you think you do have a bailout option, then you probably ought not to be putting them to sleep. SOPs and checklists, they're really good. We know from the WHO checklist that it has been associated with a rapid reduction in mortality and complications in patients undergoing surgery. So we know that they work, they make your practice more consistent. There's been reports and studies showing reductions in complication rates after the introduction of RSI checklists used through emergency department intensive care units, but also in the pre-hospital setting. But it's also important to understand that whilst they do effectively reduce some complications, for example, in equipment and preparation errors, they're not a substitute for technical skill and experience. And they also do not necessarily modify the presence of difficult patient factors. There's several national guidelines for prehospital airway management, and they are designed obviously to describe best practice. And I've put a number of them up here. I think all of them place emphasis on delivering high quality airway management, whether it's basic or advanced, and particularly that the airway management that you're providing should be in line with that can be provided in hospital. You must be able to provide the same standards outside hospital as in hospital. Again, the guidelines highlight the fact that if you don't have the team, the skills, the clinical capability to do certain interventions, just do the basics really well. Because as I said, we don't know really for certain that really good basic airway management is necessarily that much worse than intubation, and there's often a risk-benefit analysis to be thought about. I think individual systems should try and ensure compliance with guideline standards. And then I just wanted to highlight briefly the NICE guideline, which talks about intubating patients within 45 minutes of injury. And I think this is a really good standard, and we know that the faster you do stuff, often the better the outcome. A recent study by the Photon group looked at this and concluded that only 25% of patients actually meet that criteria. So the mean time to intubation is 55 minutes as opposed to 45, but actually the data from TARN suggests that that's even less really. So it's something that can be aspired to, but may have to be reviewed. But I think it's just being able to identify and get to these patients quickly. One of the really key things is to make sure that you plan for failure, because it will happen, and it just needs to sort of be an accepted part. You need to all you can to prevent it, but you also need to be really prepared for what you're going to do if and when it happens. So part of the management is the mental preparedness and bandwidth to manage the problem. And verbalizing sort of failed intubation plan is really important and should be part of your sort of decisive management plan. If something isn't working, change it. Don't keep repeating stuff that isn't helping, and make small adjustments that can optimize the intubation attempt. So adjust the position of you, of the patient, think about your choice of laryngoscope blade, and certainly for direct laryngoscopy, I would always, I'm sure most people do, pick up a Mach 4 rather than a Mach 3, because you invariably often need to change up from a 3 to a 4, but not down from a 4 to a 3. So start off with the blade that's most likely to give you the best success. Make sure you suction the airway if you can't see anything, remove the cricoid if you need to, and you may need to use external laryngeal manipulation. All of these little bits make up your 30-second drills. So each time have your 30-second drills thinking about position, laryngoscope, suction, etc. And again, don't repeat ineffective maneuvers. Your surgical cryothyroidotomy should be part of a decisive management plan. It shouldn't just be reserved as your absolute kind of, oh my God, what's going to happen if it all goes wrong? So there may be some patients in whom it should be considered as a first intervention. So severe burns, severe maxillary trauma, or entrapment. I'm not suggesting that we should be doing cryothyroidotomies on all of these patients, but I am suggesting that it's worth thinking about them in certain patient groups. So it's not always only your absolute plan D, end of the road failure management. I would suggest, and I think all the data and all the guidelines now suggest that needle technique is unreliable. So the success rate with a needle technique is 66% versus over 90% with surgical techniques. And also, needles are only ever temporary solutions, as you know, and they always have to be converted to a proper surgical airway. You don't need much kit for a surgical airway. It's quick and easy. And it is, the needle technique is no longer recommended by the major guidelines. I think it's really important to think about your post-intubation care. So the actual intubation itself is a really small bit of the process from a time point of view. So you need to do all the stuff before and all the stuff after really well. So, you know, if patients aren't managed properly post-intubation, they can come to as much harm as if you're struggling, you know, if they have a difficult or troublesome intubation. So think about lung protective ventilation. Think about, are you oxygenating adequately? Are you ventilating? Are you controlling your CO2? Make sure you've got enough agents to anaesthetize the patient once they're actually intubated. So once you've used your induction agent, how are you going to keep them asleep? That's really important, obviously. Make sure all your lines and tubes are secured. Think about temperature management. We know that people who get cold do much worse, and we shouldn't be letting these patients get cold, isn't it? Well, you know, they do worse in terms of clotting, etc. So I know there's lots of trials looking at targeted temperature management in specific patient groups, but on the whole, if a patient is anaesthetized outside hospital and allowed to get very cold, that is considered to be detrimental to them. So think about how you're going to keep the patient warm. They're often sort of stripped off to be skin to scoop. You know, if the air temperature is 2 degrees and they're lying on a road for an hour and then stripped off and anaesthetized, obviously that may be quite significant. Think about where you're going to triage the patient to, keeping all your documentation up to date, making sure you're thoughtful about your handover so it's concise and quick. I'm sure that many of you have handed over patients in hospital, but when you arrive, they're usually met by a big trauma team. It can be quite a lot going on and quite noisy. So make sure you are able to get control of that and give a concise handover. And data collection, I'm going to talk a little bit about later. And I think the key thing to say is that just because it's difficult at times in the pre-hospital setting, it's not an excuse for low standards. So it may be raining, it may be dark, but we know these things. We know that particularly in the UK, it rains a lot. It's dark 50% of the time. I mean, you know, we still need to be delivering the same standard of care as we would deliver in a hospital. If we're making the decision to go out and treat these patients in the pre-hospital setting, we have to be doing it properly. I'm going to touch a little bit on ventilation. As I've said, I think this is a really important aspect of your post-intubation care. So you need to make sure that you're appropriately oxygenating. So I'm not going to go into hyperoxia because there's many more people who know much more about it than I do, but it's something to be thoughtful about as much as hypoxia. Make sure you manage your CO2. So target ventilation to CO2, particularly in traumatic brain injury. We know from all the intensive care studies that lung protective strategies are beneficial. And we can start all this stuff outside hospital. It's really important to be thoughtful about this. Again, manual versus mechanical ventilation. I just wanted to extend into this a little bit more because I think it's quite hard to get ventilation right. So looking at using manual versus mechanical ventilation in the pre-hospital setting. One study showed that whilst the median end tidal CO2 for all patients was 4.2, so that's about where you want it to be because you're sort of ventilating patients, you know, almost sort of doing your almost assuming brain injury, I guess, in all patients, doing your neuroprotective ventilation. But the range for this value was actually from 1 kilopascal to 9.5 kilopascal. So obviously significantly over ventilating and under ventilating the patient. So the data below shows the amount of time that the ventilation was kept within the target range. So 4 to 4.5 being the target range. With manual ventilation, it was only 25% of the time, and really not much better with mechanical ventilation, interestingly. And even if the 3.7 to 4.8 is correcting for machine error of 0.3 kilopascals, so even then, you're not really capturing, you're still missing 50% of your patient group who aren't receiving adequate ventilation with manual ventilation, and 40% of your patient group with mechanical ventilation. And I think this data is surprising, but we really need to be thoughtful about this. Having sort of talked quite extensively about technique, I just wanted to touch on governance, which I'm sure is something you're all familiar with, but it's a really important aspect of what we do. We need to be doing regular training. We need to make sure that all our practices are safe. And I think using SOPs and checklists in particular can help improve the safety of the interventions that we deliver to our patients. Data is really important. And one of the things where I think we dropped down in pre-hospital emergency airway management is not having the ability to collect all of the data that we need. And as I say, even looking at the trials, well, not so much the trials, but the studies that are out there, they are so heterogeneous in terms of what they, sort of the methodology, the data they report, and therefore the conclusions that they reach, that it's really difficult to interpret them. So I hope in the future we can have a really standardized system where we all contribute to data collection, and then we can do proper research on that, proper audit. I think key performance indicators are becoming more common, and certainly the AAGBI guidelines, Association of Anaesthetists for Great Britain and Ireland, have certainly recommended them. And I know that people in services around the UK, I'm not sure about the wider world, but around the UK are starting to use KPIs, which is really great, and I'm sure will contribute to improved practice. Just wanted to touch on a couple of issues kind of skirting the edge of pre-hospital emergency anaesthesia. So videolaryngoscopy and apnea coccination. Again, with videolaryngoscopy, I think the jury is out probably on both of these interventions. So looking at the data for videolaryngoscopy, it does improve your glottic visualization, and it improves the first pass success rates, but that's generally because you're taking longer to intubate. So the time to successful intubation is usually increased in the studies, but the first pass success rates is increasing. Now, that's not a bad thing, because we know from, again, some of the very early studies that the more times you try and intubate somebody, the worse the outcome. So 2 or more intubation attempts are associated with an increase in morbidity and mortality for patients. So if the videolaryngoscope can enable us to just have one really good attempt, then that's probably helpful. But it doesn't, just because you can see it doesn't necessarily mean you can get in it. So I think a little bit of doubt perhaps around videolaryngoscopy. But one thing I think is really important is that it's really good as a training tool, and really good for the team and for situational awareness. And I think it's, for that point alone, it is a powerful tool. But as I say, the actual data on first pass rates and time to successful intubation, etc., is not so strong. Apnea coccination. So to touch a little bit on this. So the theory behind this, so it extends your safe apnea time. So that's the time until the patient starts to desaturate. So basically, looking at your oxygen dissociation curve, you get to sort of about 88, 90%, and then you go down the straight bit of the curve. And so you hit the inflection points. Any further decreases in the PaO2 leads to rapid decline in saturation. Now, the theory behind apneic oxygenation is that if you have a patent airway, which is the key bit, then the difference between the uptake of oxygen and the excretion of carbon dioxide creates a negative pressure gradient of 20 centimeters of water about, so it means oxygen moves down from the upper airways into the lungs. So if you're continually infusing it in the top, then you're likely to improve your oxygenation. Now, the data is, there's loads and loads of studies on this, and there definitely isn't time to look into all of them, but I guess the summary is that it does increase your time to desaturation in difficult or prolonged intubations. It's felt that if the patient is severely hypoxic to start with, then it's unlikely to be of benefit. But actually, some of the work I did looking at this, it showed that it may result in, so if you have, for the really hypoxic groups, the SATs are sort of 85 or less, then they had a better recovery post-intubation. So they brought their SATs up faster after intubation, after successful intubation, if they'd had apneic oxygenation to start. So there's several meta-analyses as well on this topic, but generally the main ones for emergency intubation, they, as I say, they do suggest increased peri-intubation SATs and less hypoxia, but it's not, some of that's not really been replicated in sort of randomized controlled trials. So it is a more tricky consideration, but I think ultimately you're doing an intervention which is probably harmless, which may help, and there is a suggestion of benefit, as I say, in some patient groups. And so I tend to use this in my practice. I think, you know, particularly if you're just using nasal prongs, which is the study that we were doing, so just nasal prongs at 15 liters a minute, I think you're unlikely to do harm, and you may improve your oxygenation for your patients. So coming to an end, a little bit to talk about what's next. So I'd like to think that perhaps going forward, the guidelines that are being written and updated regularly and the standards of practice that are being used are going to contribute to perhaps a more formulaic approach, which will mean that if practice is more standardized, then hopefully the success with which it's delivered will improve. I think keeping it simple is pretty important. I've talked about data collection. It would be really helpful, I think, to having, as I say, looked quite extensively at the existing research, having standardized and streamlined data collection would be really great. And I think it's just about finding the perfect recipe. So we need to think about, as I say, patient selection, the provider, the technique, etc., sort of improving every little part of the process. Just touching on the data collection, there's been some great work taking place, even in the last sort of, well, gosh, 3 or 4 years now, looking towards trying to standardize data reporting, and using a consensus, sort of a nominal group technique, to try and standardize a template for recording data to improve the research capability and therefore hopefully improve treatment strategies and outcomes. So just to finish, I think the key message from this is you need to get it right the first time, because that is your best chance at improving the outcome for the patient. So the right intervention for the right patient at the right time by the right person. We know that the injury to the critical intervention time is the most important time frame. So we want to be intervening with whatever needs to be done at the right time point, and not delaying. We're not delaying the necessary interventions, but also not performing any unnecessary interventions and delaying the transfer time to hospital. We should do the basics really well. I do believe in using a standardized and reproducible approach, and I think particularly if you're working on scene, particularly if you're with part of a HEMS team, for example, and you're coming across people who are not familiar with providing sort of high-level advanced airway management, then I think keeping it quite simple is helpful, so that everybody knows what you're doing, because then it's more likely to work. I think choice should be limited for the same reasons. The first attempt must be optimized, so every single aspect, positioning, etc., must be optimized. There should be good governance and good organizational structure for all of this. And I've banged the drum on data collection, so I won't do it anymore. But that's it. Thank you very much. And if there's any questions, then I'm really happy to try and answer them.
Dr. Kate, thank you so much indeed. That was an amazing presentation, and how you managed to get all of them slides into that time slot is pretty amazing. So thank you so much indeed.
Thank you.
So what I'm going to do, Dr. Kate, is, if it's all right, there's lots of questions coming, but I'm going to let you click on the ones that you want to answer live. And I'm just going to tell people what's happening in the world of trauma care for a few minutes. There is so many thank yous about to come through now. I can see them all starting to come through, throwing the chat up. But there's lots of people from literally all over the world tonight joining us. Yeah. And so we managed to get a good audience of almost 380 people, which is amazing for Wednesday night. So thank you so much indeed for supporting trauma care, all of you. It is so much appreciated. I'm going to show you, because I'm just about to pop the trauma care shop up, but we've got some amazing books here. We've got the Pre-Hospital Care Manual. I've just spotted Professor Sir Keith Porter in the audience. So there's one book. We've also got not very many copies left of this, of the Pre-Hospital Care Manual. So please do jump over to the Trauma Care shop for those. And we also have the Trauma Care Manual 3rd edition. And we also don't have many copies of those left, because we beat the good old big shop where everybody goes and buys them quickly with one click. So if you want your copy of those books, please jump over to the Trauma Care website, which I'm going to show you now. So I'm just going to share my screen, because I'm going to show you where you can register for some more up and coming webinars, but more importantly, where you can also get your tickets for the up and coming conference. So if you go across to traumacare.org.uk and then go across to the webinar tab, you can see the up and coming webinars there. So you probably came there tonight, maybe, to register, but you can see we've got a webinar the 23rd of March by Nick Crombie, and we've also got AI in trauma care, which I'm guessing is the future of artificial intelligence. So please do jump across to the Trauma Care website. We also have the shop there, so you can buy some Trauma Care merch along with these books, and they're all inclusive of postage and packing. So please have a little peep. And then, of course, we have got our 2022 conference, where the tickets are now live on sale with the programs. So please jump across to the website and grab a ticket today. Maybe you've got some friends or family who've got presents or birthdays or celebrations coming up. So buy them a Trauma Care ticket for the conference. Why not? And we'll hopefully see you there. So I'm just going to pop my presentation back up, Dr. Kate, and then we'll go for some questions and answers. So let's have a look. Let's go.
There's a little bit of discussion around whether, partly whether we should be doing the intervention, I think, is coming through. And also there's a question about, I think I can answer some of these like almost in a one-er. So there's some questions around how you gain the experience, which I think is really difficult. And I'm certainly, there's many other people who are better qualified to speak on this than I am. But I think, it is hard, even, I obviously work in a hospital and work in theatres, and it's hard even for the anaesthetic trainees to get experience of intubating. So it's really difficult when trainee paramedics and other allied healthcare professionals are coming in to try and get some experience. But I think most people are really motivated to try and give people as much exposure as possible. But I do think, I don't know whether the system will change. And as I say, I'm conscious that sort of Professor Sir Keith Porter's on this chat and may want to contribute, but I don't know if practice will change, and to perhaps focus more on training up a small group of critical care paramedics as we are at the moment. And then so trying to give a smaller number of people quite high intensity training to develop the service and the delivery of the service that way, because I really do believe that this is an intervention which it's just the stakes are too high. If you can't do it properly, I think it's too risky to do, because as I say, the things we don't know really overwhelmingly, although the data was from cardiac arrest patients, there wasn't a really strong signal that intubation is much, much better than any of the other stuff we do. And I think the more you do it, the more you're better at it. So I think probably potentially the system will move towards just really focusing on training up small numbers of critical care providers. There's a little bit in the group the talk about whether we overuse the intervention of intubation. And again, I think the thing that came out strongest for me, so when I looked at the study using the TARN data with sort of 11,000 patients, is the group who needed some form of airway management outside hospital but weren't actually intubated, they did so badly. And that absolutely tells you that there are patients there who need intubation. And I think we've got to be thoughtful on so many levels about it, as I've tried to talk about tonight. But I would say definitely, just because you can't do it definitely doesn't mean you should for any pre-hospital intervention. It has to be really focused and really thoughtful. Obviously, you don't have a lot of time to think about it, but you do have to be thoughtful about it. And I think that, but there are a group of patients who absolutely need it.
Dr. Kate, thank you very much. You are right. You answered about 5 questions there in that one. So absolutely fabulous. I am aware that time is getting on. So thank you very much. I will forward some of these questions tomorrow to Dr. Kate, along with the very complimenting messages in the chats. We literally have got people from all over the world. I've scrolled through the chat and it's just amazing. There's so many of you. We have just had 5 new members join us tonight. So again, thank you so much for those people who's just joined Trauma Care. I promise it will be uber worthwhile for you, and please do make sure you say hi if you have got tickets to the conference, and so we will all be there. Just before we go, I just want to say a big thank you to our sponsors. We've got a few sponsors I'd just like to mention tonight. We've got Galen, who are the manufacturer of Penthrox, and again, if you scan that QR code, Galen have got a Penthrox University, so you can jump over there, or you can Google search Penthrox and just pop over to their website and have a look. And they've got some very interesting research around pain relief and inhaled analgesia. We've also got our colleagues at Safeguard Medical, who are the producer of water gel technology. And again, you can pop over to watergel.com, or you can pop over to safeguardmedical.com. And again, all of these sponsors will be at the up and coming Trauma Care Conference, where they'll be exhibiting some of their amazing kit. And again, a big thank you to our third gold sponsor tonight, who's Icarus. And again, they're recruiting, so pop across to icarus.com and have a look at their website. And again, there's lots of very useful learning resources on there. So Dr. Kate, all that leaves me to say is thank you so much indeed for your time tonight. And we got through this. We got through it. Easy. Easy. Ladies and gents, if you're at home, please relax and enjoy the rest of your evening. If you're at work, please stay safe and thank you for doing an amazing job. But the ones at home, kick off your slippers, enjoy the rest of your evening. Maybe go and get yourself a peppermint tea. Maybe go and get yourself a little glass of white wine. Not that I'm advocating wine is good at night, but of course, it will help you relax. Take care, everybody. Have a good night and see you at the next webinar. Thank you. Bye-bye, Dr. Kate.
Bye-bye. Thank you. Thank you.